Hello, my name is Steve LaCroix. I'm the clinical manager for Mercury Medical. I'm a 35-year paramedic and a greater than 35-year respiratory therapist. And I'm going to talk a little bit today about the AirQ Laryngeal Mask Airway. The AirQ has been around for a number of years. It was invented by an anesthesiologist, Dr. Daniel Cook. Now, laryngeal masks have been around for a number of years. Dr. R.Q. Brain was the original inventor of the device. However, over the years, there's been some significant changes in laryngeal mask. There's dozens of different versions that are out there. So if I was going to be looking at a laryngeal mask, what would I look for and how would I compare some of the differences between what may be out there from different manufacturers? Now, the first thing I would always look at, and I'm going to show you, here's a AirQ here, is I always tell people, look at the bowl. Look at the bowl. The bowl is going to tell you, is it a first generation or is it a second generation? There has been some significant improvements between the generations that are out there. Now, first generation laryngeal mask airway, and I've got kind of a simple version here in my hand. And if one thing I tell people to do is to take the two laryngeal masks and put them nose to nose. And what do they look like? What does the bowl look like differently? If you look at the one here, it looks very flat bowl. Very flat bowls have a tendency not to seal. They're not anatomically designed. They're not going to fit people as well. And if you don't have a good seal, you obviously have a greater chance for aspiration or getting good chest rise or good volume with patients if I can't get a good seal. But if you look at the AirQ and look at that bowl, look how it's built up in the heel. It's pretty narrow at the front. It's more anatomically designed. So if I was going to be comparing laryngeal mask, is what does a bowl look like? Is it first or second generation? Now, the original laryngeal mask airways, and some people call them LMAs, that's just one version of the laryngeal mask airway, is that they had a tendency when you would first put them in that you would run them along the roof of the mouth and you would hit right around about C1 and C2 and have a tendency to fold back. And then when it was seated, the patient could aspirate because the tip would fold back. What Dr. Cook has done is he's taken, and I'm going to zoom in a little closer so you can actually get a good view of the bowl, is to prevent that from occurring, he put in these little ridges here. And those little ridges are designed to keep it from folding back and preventing some of the problems that was with the first generation. So what has the bowl done to help prevent that major problem? So anatomical design and the folding back. Now, every patient out there has an epiglottis, obviously. So the airway has to do something with the epiglottis, or at least it should do something with the epiglottis, because this can be kind of a partial airway obstruction, or it could be a complete obstruction with some airways. If you look inside the bowl here of the AirQ, there's a little shelf that sits up at the top there. It's got a little hole in it. And the little hole is designed so you can't create a vacuum and actually suck the epiglottis and block the airway, but the epiglottis is designed to sit on top. So it's going to keep it out of the opening here. It's going to be sitting up on this top up here. So it's done something with it. Now that becomes important later on if you want to intubate through your airway or if you're going to use a fiber optic scope at the hospital or something. But what did it do with the epiglottis? I'd ask that question is to anybody who was showing me a laryngeal mask, what are you doing with the epiglottis? Now, since this is an intubating laryngeal mask, which means you can intubate through it blindly, is getting that epiglottis out of the way is key. So it's important that question get asked. So we've got the shape, we've got the non-folding back, we got the anatomical design that's going to make it much better for us. And right in the center, a little bit hard to see on the video, but right in the center there's a little pyramid there. We call that an elevation ramp. Now what the elevation ramp does for you, or does for your patient, is that when you intubate through it, and I'm going to demonstrate this in a few minutes, is that the tube will come out and hit that ramp and it directs it up to the glottic opening. So it improves your odds of intubating blindly. Now, the odds of getting it in blindly is right around probably in the low 70%. But if you remember that burp technique, that backwards, upward, right pressure, that would improve your odds greatly to blindly intubate through it. So it gives you a capability that a lot of airways don't have. The advantage of being able to intubate through the airway, if you're using an airway currently that you can't. Now, when you get to the hospital, if you put in an airway that can't be intubated through, the physician is going to have to make some decisions based on what you have used. Now, do they either want them intubated or do they not? But if they do, in most cases, they're going to want to. They're going to have to pull your airway out if you can't intubate through it, which you go from a secure airway to an unsecured airway, try to get a secure airway. So a lot of us had learned that once you have an airway, we always try to want to maintain, we don't want to lose that. So if I could intubate through it, the patient never gets exposed. So it's a very safer situation, and you don't negatively impact what the next person wants to do. So you'll also notice with some of the tubes, some of the laryngeal masks, if you look at this one, it's very flat, very straight tube, where this one is more anatomically designed, so it's going to secure and fit better. It also works much better as a bite block. Now, there are color-coded tops on them. The purple is for adult males. There are 7 different sizes, as you can see by my rack here. I've got a large adult in the purple all the way down to a 0.5, which would be for a premature baby. The 0.5 has a dark blue cuff. That just indicates that it's a reusable. Currently, we don't have a disposable 0.5. Not a lot of EMS folks are using that size, but it's coming around in surfactant administration in the hospital, so we may see that more in the future being used that way. The original AirQ is like what I have in my hand. You'll notice, and you can spot that because it's got an inflation line. Okay, most of your laryngeal masks, not all, have some way to inflate the cuff or inflate the bowl. So you typically hook a syringe up to it, inflate just like you would in a tracheal tube. However, you want about a max pressure, about 60 centimeters of water. We have a tendency to get those a little bit too much a lot of times. So to kind of combat that a little bit, Dr. Cook invented a next version of the AirQ, and you'll notice there is no way to inflate the cuff. This is our AirQ SP, our self-pressurizing. Now, it comes with all the advantages that I pointed out in the bowl. However, I don't have to inflate it. Basically, it's inserted, okay? Then, as you ventilate the patient with a BVM, or if they get put on a ventilator or whatever, if some of the gas is siphoned off through this little port here, and it actually fills the bowl. So it self-pressurizes. I don't have to use it. I don't have to use a syringe. Much easier, much quicker to do. So as the patient is ventilated, when you squeeze the bag, it inflates and seals, and then when you release it, drops down a little bit. Now, so your cuff actually oscillates a little bit. Now, according to Dr. Cook, isolating pressure is less damaging than a steady pressure, which seems to kind of make sense. Now, for the astute listener out there, you're going to realize that, well, if it pressurizes when I squeeze, do I lose my seal when the patient exhales or when the bag relaxes? Well, the answer is no. You're going to maintain a cuff pressure in here based on the atmospheric pressure in the chest, air pressure inside your chest, so it does maintain a seal. We have to remember we only have to have a seal higher than the opening pressure to the sphincter going to the esophagus. As long as it's above that, we're not getting air into the stomach, so stuff's not going to come past and get past the seal. So it works fine. Some people have even made this a BLS or EMT skill because it doesn't put in too much differently than putting in an OPA. So you secure the airway. If somebody wants to intubate through it, they can. I recommend if you intubate through it in the field, leave the AirQ in as a bite block and let the physician or the therapist in the hospital actually make that exchange in a more controlled environment. So, okay, there is also another version that's out there called the AirQ blocker. You notice it's got the inflation line, same characteristics in the bowl, but it adds a channel for a gastric tube. Okay, so for those that are putting in oral gastric tubes, that may be something that you may find an advantage. Now, Dr. Cook also makes what he calls a blocker tube. The blocker tube is designed to go into the channel, get inflated, and actually block the esophagus for stuff coming back the other way. Does cut down on the mess and problems, reduces any possibility of aspiration. So this is what he calls a blocker tube to go into the blocker channel. Now, the blocker version is only available in the adult sizes, which is the yellow, red, and purple, which is 2.5, 3.5, and 4.5. And the most current version that's out there now is the AirQ SP blocker, which comes with the blocker tube without the inflation line. So it's a combination of all the things that which you may want to have. So you can either get a plain air cue with inflation line. You can get the plain air cue self-pressurizing. I can get an air cue that I have to inflate with a blocker channel, or air cue SP with a blocker channel, however which way that I would want to do it. Now, if I was going to intubate through this, this has been put in place. They're ventilating the patient, the airway's secured, all the other therapies are going on. They get to the point that they want to place an endotracheal tube. So I would take my endotracheal tube. Now, it doesn't have to be a special tube. It can be really whatever type of tube that you're using. The size of the tube that will fit is on the side of the airway. For the largest one, goes all the way up to an 8.5, so you don't have to use a smaller tube, which would make your RTs happy to worry about changing that out. But if I wanted to intubate through this, it's in the patient. I have to pop off the connector, and then I take my endotracheal tube. It'd be good to lube it up nice and good, and then stick that in. And you'll notice, now watch when it comes out the bowl. What direction does the tip go? You imagine where the glottic opening is, and as I do that, you can see it pushes it up into where the glottis is. So the patient would now be intubated, and you inflate your cuff, and you're pretty much good to go. Now, I'd recommend, like I said earlier, leaving it in place pre-hospital as a bite block. And when they get to the hospital, controlled environment, we're going to take it out. Now, this is where it becomes very helpful because I never expose the airway again. So think of the safety of the fact that I can make an exchange with reducing the great possibility of the patient vomiting aspirin, because we know what happens most of the times when airways are removed. So what happens, there is an exchange stylet that was used. At not time it could be kept at the hospital. That's what I see systems that are doing. And if I want to leave the endotracheal tube in and take the air cue out, now the first thing I'd do, I'd put a little bit of lube on the cuff here. So I'm going to spray that just so it's nice and easy when it slides through. I'm going to take the connector off of the endotracheal tube. I'm going to take my exchange stylet. Now, even with this in, the patient can breathe. There's channels in it. Now, I'm going to use this to hold the endotracheal tube in place, okay, while I pull the air cue out of the patient, okay. Now, I can dispose of that. This is still in the patient, put my connector back on, and now the patient is intubated without ever exposing the airway. I think we find that a significant advantage, and very few airways, if any, are set up to actually do that. They either have some bars that block the tube from coming in, or just the anatomical design does not set itself up to be able to intubate through it. So in addition to all of those design features that make this a much better airway, it's generally a cost-effective airway. The air cue is significantly less expensive than laryngeal tubes, and it's pretty marketable as far as compared to other laryngeal masks. But when you sit down to compare them, definitely look at that bowl. What's it telling you? If you took this version here and I just held up and looked at the bowls, look at the smaller opening that this one has compared to this one. Now, if every airway, I was taught when I went to respiratory school many years ago, is that once you get an airway, you don't want to lose it. So a lot of them will tell you in their directions that if you put them in and you don't get a good seal, you have to pull it out and go to the next largest size. Well, what if I'm already at the largest size? What do I do? Well, now you kind of stop. Now, so the one that's got the larger opening is probably going to accommodate a greater variety of people. Now, most laryngeal masks will max out at about 100 kilogram patient. That does not mean you can't use them in larger patients. However, when you go to an obese patient and you put a laryngeal mask airway in, it has to be used with caution, and that's with any laryngeal mask airway. Because of the higher pressures you have to ventilate those folks, you have a good chance of losing your seal. And that's not just air cue, that's with every laryngeal mask airway. But I would rather have a decent airway as compared to no airway, because we know intubating some of those folks are very difficult. So laryngeal masks come with a lot of positives. So again, start with the bowl, look at the anatomical design, look at the difference between first and second generation. What's it do with the epiglottis? And can I intubate through it? And what's the impact on what it's going to be when the next person takes care of your patient? So I hope this was informative. Again, I'm Steve LaCroix. If you have any questions, you can always email me at slacroix, that's LECROY, at mercurymed.com. Have a good day.